Hello and welcome to Advanced Assessment of Heart Disease, Moving Beyond Outdated Models. My name is Adair Anderson. I am the Product Marketing Educator here at Vibrant and just want to go over a couple of quick housekeeping items before we get started. All attendees are in listen-only mode. If you have questions during this presentation, please submit them as a comment. We will have time at the end for Q&A. This webinar is being recorded, and you'll get a copy of the recording and slides after the webinar ends. And now I'm pleased to introduce you to Dr. Joel Kahn. Dr. Joel Kahn is of Detroit, Michigan, is a practicing cardiologist and clinical professor of medicine at Wayne State University School of Medicine. He graduated summa cum laude from the University of Michigan Medical School. Known as a heart doctor, Dr. Kahn has triple board certification in internal medicine, cardiovascular medicine, and interventional cardiology. He was the first physician in the world to certify in metabolic cardiology with P4M/MMI and the University of South Florida. He founded the Kahn Center for Cardiac Longevity in Bingham Falls, Michigan. Dr. Kahn has authored scores of publications in his field, including articles, book chapters, and monographs. He writes health articles and has 6 books in publication, including Your Whole Heart Solution, Dead Execs Don't Get Bonuses, The Plant-Based Solution, and Lipoprotein A, the Heart's Silent Killer. He has regular appearances on Dr. Phil, The Doctor Show, Dr. Oz, Larry King Now, and The Joe Rogan Experience. He has been awarded a Health Hero Award from Detroit Cairns Business. Dr. Kahn also leads the annual online summit, Reversing Heart Disease Naturally. Take it away, Dr. Kahn.
All right. Thank you very much, Adir. Welcome, everybody. Everybody's time is valuable. I really, really care about this topic. The fact that heart disease remains the #1 killer of men and women. We don't handle heart disease correctly. We handle cancer pretty well. We don't screen for heart disease. So we're going to talk here. It's still Heart Month, the end of Heart Month, about advanced assessments of heart disease. I'm in my 36th year of practice, many years of training before then. I've been a cath lab doctor, a stent doctor, CCU doctor, but now I am a preventive cardiologist in about 25 states in America and some international patients. And there's so much work to do. So thank you for learning with me. Let's go to the next slide. So important. A healthy person has 100 wishes, but a sick person has only 1. There's so much truth to that. And we know that heart disease is so frequent and so often interferes with people's quality of life and their quantity of life. So it's a dream stealer, heart disease. It's the biggest dream stealer there is. And how are we doing in the United States? Not so well, actually. This is a fairly recent insurance prediction for 2030, not that far away. But there at the very bottom is where longevity, and that's not even maybe the most important number, life expectancy. Some would argue health span, how many years of your life you're healthy and free of encumberment by medical illness. But we're way down there. We got a lot of work to do, and we'll see if the next 4 to 8 years going on will restore some health in America. But I'm telling you, what we're going to talk about today can definitely restore cardiac health. And I already introduced a word. You probably know it, health span. Health span is not simply adding years to your life. Let's live 100 years, 120. You don't want to do that necessarily with a feeding tube and a tracheostomy and a wheelchair. Let's talk about adding life to your years. 80% of disease, the ones that rob us of quality of life, are preventable with lifestyle and testing and nutrition. And we're going to talk about how we're going to learn how to prevent heart disease today. So just one last comment on what we'd really like would be the bottom green arrow, a health span that's very long. And at the very end of a life, we deal with some medical issues and pass, versus what's happening today, which is about 1/3 of people's adult life is spent with dealing with the big chronic diseases, the heart disease, the cancers, the diabetes, the dementias, the arthritis, the lung disease. It's not fun. It's very expensive too. So we want to move from the top arrow to the bottom arrow by learning about aging, learning about youthfulness, something called juvenatology, and learning about disease prevention. Overall, there has been quite a bit of data saying that genetics play a role in lifespan. It's not the biggest part. Health, lifestyle is the biggest part, but at least in this analysis in 2022 in the published literature, 40% of human life expectancy is inheritable, measurable. Lifespan impacts those genes depending on what you eat and whether you're active and exercise and sleep and manage your stress. And you probably have heard of a gene called ApoE, apolipoprotein E, and there's a version called ApoE4. And if you inherit that from both your parents, it may be the strongest predictor that you really need to focus on your healthy lifespan and other activities to avoid premature disease. So we want to plan for a long and healthy life, but it has to start with a focus on the heart. And I attend a lot of biohacking and longevity conferences and webinars and seminars, and I do not hear a lot of people talking about the heart. So we're going to change that up today. Okay, we got time to go through it all. So step one, make your heart health a priority number one. And if you're a practitioner, make the heart health of your patients priority number one, above cancer, above metabolic disease, above sleep issues. Make it number one because it deserves that spot. It's the number one cause of death worldwide, 17, 18 million deaths, and it is costing us a fortune. And the United States is leading the way for heart-related expenses that are dragging down our budget. Busy slide, but really interesting. And it makes the case that I feel that we don't pay attention to heart disease the way we should, which if you look over to the left in 2016, 30.2% of deaths in the United States were due to heart disease, 29.5% due to cancer, then road accidents, respiratory disease, Alzheimer's, and others. But the next column from all the way over on the left, where there's blue and yellow, is when people go to the computer and they search for causes of death. Only 2% of people are searching on heart disease topics. 37% of the time, it's cancer topics. 11% of the time, it's accident topics, and on, including suicide, homicide, and terrorism. So people aren't being receptive of the message. Search for heart disease data, search for heart disease evaluation. And part of that is the last two columns on your right. That's the New York Times 2016 and the English paper, The Guardian 2016. When they write about death, only 2% of the time are they writing about heart disease and death. And even cancer doesn't get the full display in the news, the media, where people are going for their information very often. And you see that the news, the mainstream media, as people call it, are reporting on terrorism and homicide and suicide is the vast majority. And those are all very important topics. But it should be that a third of the time, the New York Times and the Guardian and every other media outlet should be talking heart disease, heart disease, heart disease. So here we are today with Vibrant Labs talking about heart disease. So step one was make heart health a priority for you and for your practice if you're a practitioner. Step two, it's never too late. It's also never too early. This is a classic slide of autopsy data, unfortunately, of soldiers who served in the American military and died from bomb blasts and gunshots. And how often did they have atherosclerosis in their heart arteries at age 18, 19, 20, 21? And there has been a shift. It's a little less common, mainly because smoking is so much less common. And it was that almost 80% of, unfortunately, soldiers that served and died in the Korean War showed signs of atherosclerosis and all. And some of them showed severe atherosclerosis in their 20s. Now, the most recent analysis was for 2011 in the Iraq War. You can see it's fallen, which is good. That's good news. Maybe we're doing better with blood pressure monitoring and cholesterol and blood sugar and insulin resistance management and the rest. But it's still never too old. I would love every 18 to 20-year-old to get a very thorough lab panel. We're going to talk about lab panels and identify early in life what they are carrying in terms of metabolism and genetics and what their lifestyle is doing to their labs. And we'll show some examples of that I think are very exciting. So it's never too early to check the heart, and mainly with lifestyle education and blood work. It's also never too late. A healthier lifestyle improves the odds of living to 100 years at any age. This was published last summer in JAMA. Even when a healthier lifestyle is initiated at age 80 or older, people with the healthiest lifestyle scores improve their odds of reaching centenarian status by 61% in comparison to those with the lowest scores. So if you know an 80-year-old and they're saying, I want to live to 100, and you're having this discussion over a cheeseburger and French fries, it's not working for them. They need to have a fitness program and a sleep program and a stress management program, a good dental program, a good sleep program, and certainly a good nutrition program. All right, step 3, which is we know why people die in the United States. And these are data that goes back a couple decades. It's still very valid data. I just read recently there's an initiative in the government to update this data. But if you look at the left, that's in the year 2000, causes of death in the United States. We just saw a similar graph in 2016. But when this was analyzed in 2 published articles, there were 3 major reasons people died in the United States: smoking, poor diet, and physical inactivity. And in fact, those 3 things accounted for about 80 to 85% of deaths in the United States. And I just want to say that again: smoking, poor diet, and physical inactivity. I have a friend, Dr. David Katz, medical doctor, who's in Connecticut, and he calls it fingers, forks, and feet. Fingers, do you have a cigar or a cigarette in your hand? Forks, what are you doing with your diet quality? And feet, are you moving them, or are you sitting too much of the day because of a job, medical disability, or other issues? Forks, fingers, feet. All right, here's actual research from 2 large studies involving about 40,000 people, real data, that when they analyzed databases, these were European databases. If you can answer 5 of 5, and one of them is certainly controversial: I don't smoke, I walk at least 30 to 40 minutes a day, I eat at least 5 servings or more of fruits and vegetables a day, I sleep 7+ hours a night, and this is the controversial one: when asked if I have a glass of wine a couple of times a week, I say yes. In fact, it was any alcoholic beverage, but that was the question asked, and that was the multivariate analysis that was obtained. That 85% of heart attacks could be prevented over about a 14-year period, compared to people that answered no to these questions. I do smoke, and I don't walk, and I don't eat, and I don't sleep, and I don't enjoy. So some of these, of course, are sort of a U-shaped curve. I'm not advocating you have to have alcohol in your life. Many people don't and are very happy with it for a variety of reasons. But, you also don't want to sleep 13 hours a day. I mean, there's a sweet spot for a lot of these. I don't think you can eat too many fruits and vegetables in a day. I don't think there's a sweet spot there. It's a straight line. Okay, step 4 is probably the most important part of this presentation. It's what I do every day with people all over the United States. Test, not guess. I think I post that on social media 5 times a day with various posts reminding people about heart disease. And it goes back to the 1600s when this physician, Thomas Sydenham, wrote the most popular textbook of medicine in that era that was used for 200 years out of England, but all over through Europe. A person is as old as their arteries. And if you could just know how healthy or unhealthy your arteries are when you're asymptomatic, when you're young or in your middle ages or certainly in your older years, you would have an idea how old you are as an entire human being. Vascular age is a term you don't hear enough. Arterial age is a term you don't hear enough. Coronary artery age is a term you don't hear enough. And they're all medical and literature terms. So how good are we in the office? And there is a society I still have a lot of regard for called SHAPE. They've been around for about 20 years. In very small letters, it says Society for Heart Attack Prevention and Eradication, supporting early detection of heart disease. But they made the case, and I'm borrowing this from them, that if we sat down with two patients, one named Sir Winston Churchill with a cigar in his mouth, probably 280 pounds, and a big fatty meal in front of him, we never would have predicted that he'd live to age 91 and be fairly vigorous. Nor if we sat across the exam table from Jim Fixx, who wrote a book in the 1970s, the Book of Running, bright red book with his legs on the cover. We never would have predicted that at age 52 or 53, he was going to drop dead of advanced coronary disease. So talking to your patients, taking a careful history, doing a careful physical exam are always crucial. And I would suggest you even expand your history taking to include sleep and dental health and childhood trauma and social support and other things you might call the whole blue zone construct. But it isn't enough. We have to test, not guess. So the question is, if you look where the black arrow is, this is a picture from a heart catheterization I took. That's an angiogram, and that's an arrow pointing at the widowmaker, the proximal LAD, although a narrowing in any artery in the heart can cause symptoms, heart attack, or sudden death. Do you know, and do you know if your patients have this problem? So here's a clue, kind of a funky one, but it's a real one, that this is a photograph of the handsome Steven Spielberg. He does not know that I'm using his picture, so if Steven's listening right now, thank you, Mr. Spielberg. But the red arrow is pointing to his left earlobe, and I can assure you when he was 13 years old, he did not have that deep crease, and it's in both earlobes. You just can't see his right earlobe. It's a little hard to take a picture and see both earlobes at once. And that's called a diagonal earlobe crease. An internal medicine doctor in the 1970s in New York City named Dr. Frank identified in his practice full of heart patients, I observe an earlobe crease in heart patients, and I don't observe an earlobe crease in my patients free of heart disease. And he published that, and it was forgotten after some conversation. But with the advent of heart imaging studies that are easy to do, which we're going to talk about, it's now estimated that if you see an earlobe crease, it's got a sensitivity for coronary disease of about 70%, which is about the same as a stress test on a treadmill. There's a theory that your earlobes are made of collagen, your arteries are made of collagen. In fact, collagen is the most abundant protein in the body, about 50% of all protein in the body, and that we are very prone to weak collagen in the body. It has to do with our inability to make vitamin C. We're one of the very few species on the planet that can't make vitamin C. So this is the collapse of the collagen tissue in our earlobe, which may reflect the weakness and fragility of the collagen tissue in our arteries throughout our body. That's a theory, but I believe it's true. Another very important clinical warning, test not guess, you might have heart disease, is erectile dysfunction. And over 20 years ago, there started to be seminars at Princeton University, and they would publish very extensive white papers on the connection between erectile dysfunction and coronary disease. There would be urologists, cardiologists, epidemiologists. So this data is not new and is quite robust. The penile artery is 1 to 2 millimeters compared to a heart artery that on average is 3 to 4 millimeters. Atherosclerosis below the waist can show up with symptoms before atherosclerosis shows up above the waist. And a man with erectile dysfunction may deserve some education about nutrition, for sure, and fitness, and certainly lab work, but needs a cardiac workup along with a prescription for an erectile dysfunction drug if you want, or testosterone replacement therapy if indicated. They need a heart workup. This is termed the canary in the coal mine. Just for history, you might know Coal miners 120 years ago would go into a mine with a bird in a cage. If the bird stopped chirping, they would be concerned that there might be an elevated carbon monoxide level. They would get out of the mine before they got sick and bring the bird out, and the bird would be revived with fresh oxygen. So erectile dysfunction can be an early warning system. All right. What's the best test to predict the presence of atherosclerosis? According to one of the leading European experts in atherosclerosis, the best test is demonstration of atherosclerosis. We're not going to get out a little calculator like the Framingham risk score calculator, or there's one the American Heart Association introduced last year called the Prevent risk score calculator. And we're not going to rely on that alone. We're going to look at arteries, as Dr. Ernest Schaefer, a very prominent physician, suggested. So how do we look at arteries? And these are all the tools I use. Upper left is a CT scanner. Upper right is a carotid ultrasound. Lower right is a carotid ultrasound done with digital imaging called a CIMT ultrasound, a very important, safe tool. And lower left is to imply we need lab testing, advanced lab testing, not traditional lab testing. Well, how do you detect plaque earlier? And it's very important to understand this presentation right here. And we're going to go from left to right. Left is an artery with some soft plaque shown as yellow, but there's really no obstruction to blood flow. So there's not going to be any symptoms, even on the pickleball court. If you do a stress test, there's not going to be any reduction in blood flow to the myocardium, so no problem. And because it's a non-calcified soft plaque, you're not going to even be able to detect it on the most available heart CT scan called a coronary artery calcium CT scan. So you will miss this. There is now a technology called coronary CT angiography. I'm going to talk about it in a minute. But if you keep going from left to right, those little white spots are to represent calcification, a process that takes time, may be accelerated by being on a statin, may be inhibited to some degree by taking a lot of vitamin K2. But as soon as there's calcification of the plaque, you're not going to have much obstruction, so you're not going to have symptoms, you're not going to flunk a stress test. But if you do a coronary artery calcium CT scan, which I'm going to show you in a minute, you will pick it up as abnormal. You will know by looking at an artery that this patient has atherosclerosis. If you go to the column that says advanced, it's just more obvious. The stress test won't pick it up. Only at the late stages, when an artery is 70, 80, 90% narrowed, may there be symptoms of angina or shortness of breath. May there be an abnormal stress test, and there certainly will be an abnormal CT scan. So stress tests and waiting for symptoms simply can't possibly pick up early atherosclerosis. I mentioned the SHAPE Society. This is from the SHAPE Society. If you look at the bright blue box that says atherosclerosis, just imagine that you're at your internist and they say, Bob, your cholesterol is 240 and your LDL is 148, and I think you need this prescription for Lipitor. Or Mary, you're at the gynecologist and you're 56 years old and your cholesterol numbers are up. Here's your prescription for Crestor. The SHAPE Society said, why don't we propose an alternative? Let's look at arteries, test not guess, just like Dr. Ernest Schaefer talked about. Get a coronary artery calcium CT score or get that advanced carotid ultrasound called a CIMT ultrasound. If you're low risk without plaque, you don't need therapy. If you're high risk with a lot of plaque, you need therapy. Now, everybody needs healthy diet, fitness, weight control, blood pressure control, blood sugar control. So these are 3 examples of a coronary artery calcium scan. Takes about 5 seconds, no injection, no iodine allergy, no pain, no claustrophobia. You would want to be panel A, where the coronary arteries, and the yellow arrow is pointing to the proximal left anterior descending artery, or the widowmaker segment of the coronary arteries. You want to be like panel A, no bright white spots, no calcification. When the software program analyzes panel A, they say calcium score of 0. You really don't even want to be panel B, which does show white spots in the left main and proximal LAD. Maybe the calcium score is 100. Depending on your age, that may be wickedly abnormal if you're 44 years old. And panel C is like patients I have, including one this morning about 3 hours ago with a calcium score of 3,674, the patient I saw this morning. But where you're out there and you're active and you're shoveling stone, you're playing pickleball, but you have extremely advanced, probably asymptomatic coronary disease. And this can all be detected. A coronary calcium score CT scan tends to cost about $100. Now, is this a radical approach? No. If you look at this algorithm, and please don't read it all, I just want you to look at the red circle. This is from the American Heart Association, 2019, and it says there's CAC, coronary calcium of 0. Consider no statin. You can say to your doctor, I don't want that prescription. I'm going to work on my lifestyle. They do include, unless you're a diabetic, have a wicked family history of premature coronary disease, or are still smoking. And they really say the only clear-cut data to start a statin is when your calcium score is over 100. There's a gray zone when you're between 1 and 99. The carotid study is an awesome test for asymptomatic atherosclerosis. It's just hard to find a clinic that does that. We do it in my clinic in Michigan and my southern clinic in Boca Raton, Florida. But it's not easy. That's why I offer it. It's a ultrasound, painless, no radiation, takes about 20 minutes. But it's the digital software that gives you precise measurements to say you have plaque, you have soft plaque, you have hard plaque. Compared to other people your age, your plaque is more than average. And the thickness of the wall of your carotid artery is below average, average, or above average. That actually calculates to a arterial age, a vascular age. Very helpful test. So certainly my recommendation is we check the third box after we check the first two, and we add in calcium scoring as a routine recommendation to our patients. I think I have, you won't be able to see it unless you look in the little box where I am, but I always have a prescription pad with me to order a CT calcium scoring without contrast study. Thank you. And I don't know how we get back to slides. I'd let you do that. Thank you. And you order them on your patient, and all the hospitals and the CT centers offer it, usually $75, $100, $125. And we get aggressive about detecting early silent coronary atherosclerosis. So we can educate that patient, we can motivate that patient, and very honestly, so we can test that patient for why they have silent premature atherosclerosis. And we'll talk about lab testing in a minute. All right, a real revolution in my practice started in 2010, but really took off in 2020. And that was the fact I'm trained and practiced for close to 30 years as an invasive cardiologist doing cardiac catheterization. But we learned, due to better CT scanners and software, that we don't have to do a catheterization to look at heart arteries. Heart arteries are very difficult. They're small, they're not straight, and the heart's moving all the time. So it took a number of years to develop the technology, and it's just getting better and better. But we learned since 2010 that we can look at coronary arteries and see no plaque, and then we can use our visual subjective analysis to categorize plaque as minimal, mild, moderate, or severe. An imperfect way to measure plaque, one of the most important measurements. Are you going to have bypass or stents or medical therapy, or be reassured? We do it by eyeball evaluation, but this is an important breakthrough, widely available. It does involve iodine. You have to have healthy kidneys. You have to have a low heart rate. Often you take a beta blocker for this test, like oral metoprolol an hour before. And you also can't have a severe iodine allergy. You can have a shellfish allergy because the allergists generally feel that's not predictive of anaphylaxis from iodine. But the real breakthrough, as it says on this slide, is in 2020 through 2025, that we can take a coronary CT angiogram done at a hospital, done at a clinic, and we can use AI. If you look at the title of the slide, AI, everybody knows AI now. It's not aortic insufficiency. It's artificial intelligence. And we can now characterize, if you look at these 4 boxes, plaque burden. How much plaque do you have in your 3 coronary arteries measured in cubic millimeters? We couldn't do that till this technology came out. We can measure plaque composition. If you look at the second picture, it says 2. Yellow is calcified plaque. Blue, nope, take that back. Blue is calcified plaque. Yellow is soft non-calcified plaque. In red is something called low density, high risk non-calcified plaque. This patient has all 3 kinds: calcified in blue, non-calcified buttery soft plaque, which you don't see on the calcium score in yellow, and spots of red high-risk plaque that may well represent pre-infarction plaque. And we never could do that before with a non-invasive test that takes under a minute. And then we can see the entire 3-dimensional shape of the artery to see if arteries are remodeling. And finally, we can repeat a study and see if disease is getting worse or better or stable. And this is a technology that I now do all the time on my heart patients when they agree, because it is a bit more involved than the coronary artery calcium scan. It's more expensive, and many of them are paying out of pocket about $1,500. This is backed by some of the largest prospective studies. Their names are there: Confirm, Iconic, Paradigm, Scott Hart, and others. Very research-based approach. And we're learning now that not all plaque, when you say you got a 40% blockage, Mr. Smith, the intelligent question would be, well, is that soft plaque? Is that hard plaque? Is that mixed plaque? Is that low density pre-infarction plaque? So if you look at these examples, low risk on the right are the mainly calcified chronic stable plaques. Going, as you go to your left, more yellow, which is non-calcified plaque, all the way to these scary high risk, low density non-calcified plaques. And we can't measure this in the cath lab very accurately, but we can with CT angiography, a wonderful tool. So let's talk about lab work a little bit. You have this patient and you're concerned about them, and you get a coronary calcium score and it's elevated. Maybe you talk to them about artificial intelligence interpreted coronary CT angiogram. And you want to ask the question, why? Why do you have atherosclerosis at age 42 or 51 or 59 or any age? So I love this picture. It comes out of a medical journal. Daggers of arterial disease. That's supposed to be an artery with a yellow plaque. And this is not just Framingham. Framingham was smoking, cholesterol, blood pressure, diabetes, and family history. This is nitric oxide. This is homocysteine. This is hormones. This is insulin. This is omega-3. This is inflammation. There's many more. This picture is about what it says here, 2009. So we could upgrade it now to include lipoprotein, little a, genetic cholesterol, TMAO, perhaps interleukin-6 and some others. And these are all widely available. So I believe in very, very broad lab panels, blood and urine usually. And really one of the most important, step number 6, breakthrough in the last 20 years, is we have so many tests now to measure inflammation. And we have more than are seen on this picture. We have something called urinary isoprostanes, F2 isoprostanes, which measures oxidative stress along with oxidative LDL. We have markers of disease. ADMA is a nitric oxide marker, so your endothelium, is it healthy or not? Microalbumin, are your kidney endothelium healthy or not? High sensitivity C-reactive protein. We have inflammation markers that predict risk of stroke and heart attack, MPO, myeloperoxidase, and LP-PLA2 enzyme activity. And we even have markers that indicate actual damage to the myocardium, high sensitivity troponin, and there's others, interleukin-6, cystatin C, certainly lipoprotein, little a, the genetic sticky cholesterol. Aha! So this is a plea to all clinicians that are listening, as well as anybody who's in the audience that isn't a clinician. You should know your lipoprotein A genetic cholesterol blood level. This is a book I wrote a couple of years ago. lipoprotein A, the heart's quiet killer. Hopefully you're familiar with this as a concept. This is a cholesterol particle that looks like an LDL cholesterol molecule, but has an extra tail called apolipoprotein little a, with a bunch of things called kringles on them and all chock full of something called oxidized phospholipids. And it proves to be a very inflammatory particle, a very thrombotic particle, and a very atherogenic particle. And it turns out about 20 to 25% of us inherit the ability to make this cholesterol, lipoprotein little a, whereas about 75 to 80% of us make very little or none at all. It's a simple blood test that everybody should have done. And it's why they recommended now that everybody, I would say at age 18 or 20, find out. But it's never too late if you carried lipoprotein little a. I spend about half of my clinic life consulting with people from all over the United States that find out on their blood work that they inherited a high level of lipoprotein little a, and we talk about how to deal with it, which is another lecture. But if you look here, based on certain definitions, 1 out of every 5 people, in certain populations, it's more than 1 out of every 4 people, getting close to 1 out of every 3. So we're talking, nearly 2 billion people worldwide, and a very large number, maybe close to 100 million people in the United States, have an elevated lipoprotein little a to the level that it could put their vascular health, their atherosclerotic disease burden at risk. The other unique thing that lipoprotein little a does is it can scar the aortic valve and cause aortic stenosis. So if you have a murmur that's consistent with aortic stenosis, get an echo, but check a lipoprotein little a. And obviously, if your patient has that, check a lipoprotein little a. All right, so we're going to shift gears to what I think I like new, because we're not winning the battle on heart disease. It's still number one. 2025, maybe 3 weeks ago, the American Heart Association announced we will end the year with heart disease being the number one killer of men and women. So what we've been doing, we can be proud of: ambulances and coronary care units and stents and bypass surgery and statins and PCSK9 inhibitors and antiplatelet drugs and diets on nutrition and all the important factors that go into a healthy preventive heart program and treatment program. But we need to have advanced labs. We've got advanced imaging now, and that's only going to get better. We need advanced labs. So I'm very excited. And I'm waiting when in 2025, and I don't have the answer for you when, but in 2025, Vibrant Wellness is bringing us the Cardio Zoomer panel. And this is going to be a genetic panel upgraded from something they've had around for a few years that I've used a lot called the Cardia X panel. But this is going to be upgraded, much bigger, much broader. I love cardiac genetics. Patients love cardiac genetics. We've only talked about 2 so far: ApoE and lipoprotein little a, but there's many more. And we want to have advanced biomarkers that you can repeat over and over and look for improvements, cutting edge. And that's what the Cardio Zoomer is going to have for Vibrant. So it's, again, going to be 2 parts. Of course, you don't need to repeat your genetics. If you know you're ApoE2/3, you're going to stay ApoE2/3. If you know that you inherited a gene called 9p21 from both your parents, which raises your risk of cardiovascular disease, you're going to stay homozygous for 9p21. But the biomarkers need to be repeated with interventions like lifestyle and pharmacology and even supplements. So we're going to get greater insight into genetic risk and explanations. We're going to go from 31 SNPs in the current Cardia X to the Cardio Zoomer now having 100 SNPs approximately, still being worked out. And when I look at these, I get excited. If you look in the upper left, it says 9p21, a gene, if inherited from both parents, that raises the risk of heart attack. A couple down says 4q25. If you inherit homozygous abnormal versions, you're raising your risk of atrial fibrillation genetically. genes for blood pressure. And then you look a little further down, ApoE, which is a gene that's involved in total and LDL cholesterol, particularly in the brain, and can predict both cardiac disease and dementia. MTHFR gene, absolutely crucial to manage people's methylation pathways and homocysteine levels. And I'm looking over at the right, and I see some of the others there also. But these are the current 31 SNPs on the CardiaX that is available. But look at this, and I've had a chance to review some of these, but I'm eager to see, and I'd like to run this on myself, a panel of 100 plus SNPs, single nucleotide polymorphisms, that will really characterize our heart patients and allow us to educate them. But beyond the genetics are going to be repeatable markers, more than 70 markers. I get a lot of markers on my patients. Of course, advanced lipid numbers and small dense LDL particles and lipoprotein little a is mandatory. And all the inflammation markers in the lower left. One of my favorites is galectin-3, a lectin that indicates inflammation and scarring is related to heart disease and cancer and dementia. Even more inflammation markers. One of my favorites now is cystatin C. A recent paper showed that it's more sensitive than BUN and creatinine for preclinical renal disease, and also predicts poor outcome in heart patients, so you intensify therapy. IL-6, similarly, recent paper showed people with coronary disease and an elevated interleukin-6 are at increased risk and need more intensive therapy. Sterol analysis is very interesting because it helps you identify a very rare disorder called cystostarolemia, but it also lets you characterize your patients as overproducers of cholesterol or overabsorbers of cholesterol, and you might select different therapeutics based on that. All kinds of metabolic risk markers, including a lot of insulin resistance markers, which are critical. And TMAO, one of my favorite particles, a metabolite from eating egg yolk, red meat, and certain supplements. Oxidative stress markers, all the ones that we should know in our patients. Clotting markers, endothelial dysfunction markers, so we can work with our patients to improve their endothelial function. Ceramide markers, which is amazing. And then cardiac stress markers like the high sensitivity troponin level. Just absolutely, absolutely exciting panel, cardio zoomer markers. And you can repeat these and hopefully see improvements. So as we're coming to an end, we made the point, cardiovascular disease is the leading cause of death in the United States. We have to change it. Not only can we change it, we have to change it. We have to start using early detection like a coronary artery calcium scan and a carotid intimomedial thickness ultrasound. We have to teach healthy lifestyles to prevent heart disease. We got to use healthy lifestyles to treat heart disease. We looked at some of that data. I would love to talk to you more about that on another occasion. And we have to start using more advanced lab technology like the cardiozoomer panel, so we really can characterize and counsel our patients optimally. So thank you very much for being part of this February Heart Month Vibrant Wellness webinar seminar. I believe so strongly we can change the course of American medical history and outcomes in terms of heart disease. I'd be happy to take any questions if there are. I will tell you, you can find me at a website, drjoelkahn.com, drjoelkahn.com. And you can also email me directly a question, drkahn@kahncenter.com, drkahn@kahncenter.com. I'd be happy to try and give you an answer. I've written an article and a blog, I think, on every cardiology topic, so I probably have something to share with you on calcium scoring, on CT angiography, on cardiozoomer labs, and the rest. Okay? Thank you, Adair. You're back. I can't. Your mic is off. There you go.
Thank you so much for that fantastic webinar. Wow, you clearly know a ton about this, and I already learned so much from you. We do have a
Thank you.
couple questions.
Okay.
First one is from Dr. Larson, who wants to know, many women get their ears pierced. Do earlobes get creased when they have pierced ears?
Good question, Dr. Larson. I've heard it asked before. I don't have any experience personally. My wife wears little tiny earrings, thank goodness. She doesn't ask me for big, heavy ones. And I've seen women, I think, you can pull the piercing site down just from observation with big, heavy, dangling earrings. But we're really talking a real diagonal crease. It's usually not hard to tell the difference, but I agree with you. It can be confusing. Nobody's studied it scientifically. And the reality is, if there's any question, test, not guess. Find out if your patient has silent atherosclerosis. Yeah, if you live in Cleveland and you go to the University Hospital, they'll let you have a coronary calcium CT for free. So maybe next time you're visiting relatives, you go do that.
Thank you. All right, next question. Dr. Larson would love for you to show that CAC prescription again.
Yeah, no problem. And there is a CPT code. Now, in the state of Texas, these are included in the health care laws of the state of Texas. You can get one free at age 50. If anybody wants to learn more, there's a really interesting documentary called The Widowmaker Movie. Probably about 10 years old now, but it explains why the state of Texas and maybe Hawaii also permits, as part of their healthcare laws, a automatic calcium score. But you have to ask for it. I have patients in Texas, they didn't know they could get a free one, but they can. So, I put it down, but I tell people you will pay for this. Maybe 50, maybe 75, maybe 125. The old days, over $1,000 when we're talking. This test has been available for 30 years in Michigan. So it was over $1,000. So, 7,000 research studies. Every day there's new alerts and research. And it sounds like it's a brand new thing. It's not a brand new thing. It's only the radiation dose is less than a mammogram, takes about 10 seconds. It's not claustrophobic. And, you really want to know if you're zero. It's not easy if you're abnormal. Like I said, I had a patient this morning with calcium score over 3,000. It's not easy to get calcium out of the artery. It's a chronic healing finding, but it's an excellent marker to know where you stand. And I'll order one on an 80-year-old. I know it's probably going to be abnormal. It's not. I have an 89-year-old who's a zero. So not everybody absolutely gets atherosclerosis that's detectable.
Thank you. Next question is from Dr. Karsrud. Do you have any feedback on Pearl Meter's usage of uric acid as an inverse indicator for nitric oxide?
Well, I do think that uric acid is an important marker. It's one I put in my lab panel routinely. Obviously, I ask about gout, but even in people that have never had gout, I'll check. It's a good, indicator of indirectly diet, the quality of the diet, to some degree genetics. It's under genetic control. And to some degree, their risk of gout if they've never had. And it's a number I try and improve. We were getting excited. So yes, I agree with the premise. There is a better test for nitric oxide production called ADMA, asymmetric dimethylarginine, which is in the new CardioZoomer panel when we get it. And ADMA directly competes with arginine at the artery wall. And a high ADMA means low nitric oxide production. So uric acid is an indirect marker. ADMA is available now. It's a direct marker with hundreds and hundreds of research studies. You want a low ADMA level. And, you might eat different, exercise different, and use things like beetroot powder and L-arginine and citrulline and all. But so, yeah, uric acid is important. We got very excited in the last 5 years that colchicine might be a superstar anti-inflammatory cardiac drug. But after 2 very, very positive and encouraging studies, we, in the last 3 months, had one a large cardiac study with 7,000 people that said colchicine didn't do anything for people who had a recent heart attack. So we're kind of confused right now. And so my patients taking colchicine based on the early data are now actually stopping it because it's confusing.
Right. Thank you for that. Next question from Lindsay Parsons. How do you feel about the use of statins with high Lp(a)?
Yeah, controversial, great question. Because statins do not lower lipoprotein A. And as you may know, Lindsay, they raise lipoprotein A, sometimes minimally and sometimes a lot. I deal with hundreds and hundreds and hundreds of lipoprotein A patients. And a typical patient will come and see me. Their lipoprotein A is 400 nanomoles per liter, and they're on rosuvastatin 40 milligram. And depending on the setting, I might tell them, we really don't know what your lipoprotein A is because this is jacked up on a statin. And we'll stop the statin for 4 weeks if it's appropriate and repeat the blood level. And the lipoprotein A is 280. Still very abnormal, but 40% rise. And sometimes I see more than that. The literature says it, but a lot of people downplay it. I think it's really prominent. However, I use ApoB, apolipoprotein B, which is a measurement of all atherogenic particles in the blood, including lipoprotein A. And if I have to put a person with a high lipoprotein A on a statin because their calcium score is high or their CT angiogram's bad or something, I'll follow up the ApoB. And if the ApoB fell a lot, that means I've pushed the LDL particles down so much. Even if I let the lipoprotein A particles go up, it's imperfect, but I have probably benefited the patient as best we can. Because as you know, other than niacin, an over-the-counter supplement, which lowers cholesterol and lipoprotein A, and something I use quite a bit, we don't have a drug yet for lipoprotein A, and we're not going to have one at least till 2026. Unfortunately, the study result just got delayed a year that we were all hoping for.
Thank you for addressing that. Next question is a general question. Does everything you said apply also to AFib? From Kathy Haas.
Well, if I were seeing a patient with atrial fibrillation that denied angina and other things, I would get a calcium score without a doubt. We used to say there were two separate things. It was an old concept. Here's atrial fibrillation, here's coronary disease. But there are many studies now that say you're going to find a lot more coronary calcification and silent atherosclerosis in somebody with atrial fibrillation. Of course, not a 17-year-old, but a 48-year-old, I would do it. And it's an easy test. You would want to do a cardio zoomer panel when we get it on somebody with atrial fib, looking at oxidative stress, inflammation, genetics. We've got that 4Q25 SNP that's there anyways. So yeah, I would do it all.
Okay. And on a related note, at what age would you recommend someone start screening for cardiovascular disease with calcium scan, and how often should there be follow-ups? From Kathleen Arnold.
I'm just sharing my own philosophy. There's no absolute agreed upon guideline there. A lot of people judge the risk based on a prevent calculator and then order the calcium score in the high-risk people. But it's been shown we're wrong so much. I order one on everybody, and I would say, to answer your question, 45, really good age for a man, and sometimes earlier if their risk profile scares me or their family history scares me. And, around menopause for a woman, but sometimes earlier. If you come to me at age 48, you're still having periods, but your lipoprotein A is 325 nanomoles per liter, I might talk to you about getting a calcium score. You're getting mammograms, and it's about the same radiation exposure, which is the only argument not to do a calcium score would be the radiation exposure.
All right. Thank you for addressing that. A follow-up question from Dr. Karsrud. What's your take on Linus Pauling's claim of using high-dose vitamin C and lysine to lower Lp(a)?
I always have a bottle of vitamin C close by, just in case. So without self-promotion, I do a weekly podcast called Heart Doc VIP on iTunes and Spotify. And if you look, yesterday morning, I dedicate an entire podcast to this question. So it's a fun little description of old literature, current literature. the idea that Dr. Linus Pauling, who won 2 Nobel Prizes, felt and published theory that atherosclerosis is a vitamin C deficiency syndrome. And the real way to prevent atherosclerosis is to flood the body with vitamin C. So I've been sipping vitamin C powder and water through the day for probably a year now, kind of self-experimenting, biohacking. It's just unproven, but it's very safe. It's very inexpensive. Might prevent some colds and flus, might lower your blood pressure, might lower your cholesterol, might really lower your blood sugar. Some really interesting data about taking vitamin C to reduce your insulin dosing in diabetics. So I am a fan of that theory, but I recognize it's still at the level of theory. Humans can't make vitamin C. That's the basis. There's only about 5 species on the planet, humans and a couple primates and the guinea pig. Everything else makes grams of vitamin C a day. Dogs and bears, and wolves and foxes, they all make lots of vitamin C. We lost the gene in the liver 40 million years ago. So, either eat a whole lot of arugula or you eat a lot of arugula and you supplement with a little vitamin C.
Quick question related to that. I have a friend who has an earlobe crease who craves citrus fruit.
Oh, that's interesting. That's a good thing to crave.
Right?
As opposed to craving, frappuccinos. Depending on the age, that person should probably get a calcium score. I don't really recall any other patients craving citrus. But again, it is really interesting. There's a disease called scurvy when you have no vitamin C. Mm-hmm. And the US government tells us to ingest 90 milligrams a day to prevent scurvy. But it's been calculated that we probably would be making 20,000 milligrams a day if our liver enzyme called GLO wasn't lost 40 million years ago. So interesting. So maybe that person is getting a message.
All right. Thank you for that information. I'd like to finish it up by having you just repeat your website and email address again, and or putting it in the chat so people can read it. Also, just send it to me afterwards. I'll email you, and that way we can include it in the follow-up email. In case anyone missed in the beginning, this webinar is recorded. You will get a copy of the recording and the slides. And we'll also include Dr. Kahn's website and email address with that e-blast. So you will all get the contact information later and soon.
Let's see how quickly. This is what I do with patients. I always have a pad of paper, old school, and a pen. Maybe I do this better on a tablet, but I'll show in just exactly a minute. But it's drjoelkahn.com is the website, drjoelkahn.com. And Dr. Kahn, Kahn, at kahncenter.com is my email.
Super. Thank you for that. Thank you for an amazing presentation today and answering all those questions. Audience members, thank you for your great questions. Thank you for your interaction. I hope you all have a vibrant rest of your day. Take care, everyone.
Thank you.
Bye-bye.